I think by now you have likely discerned the pattern that we do for all the chapters. We talk about the osteology, then we're going to talk about motion and stability, and then we're going to talk about muscles and functional things. So the learning objectives for this part of the ankle and foot, they're kind of a lot of them, but they're all related. We want to be able to identify the joint types and the motions available at each joint, just like we do with everyone. So there are a lot of ligaments in the ankle, but I'm just going to have you focus on the two main ones. One of them's medial, one of them's lateral. There are foot joints that have nearly equal elements of the three motions that combine to make up pronation and supination of the foot. And we're going to talk about them. We want to describe the joint motions occurring at the talocrural, subtalar, and transverse tarsal joints. What the most stable position of the talocrural joint is and why it's stable, and what is the least stable position, and how does that relate functionally to what we're going to tell our patients. I want you to be able to identify the combined motions of pronation and supination of the foot, which three motions combine to make up supination and which three motions combine to make up pronation, and which structures support the medial longitudinal arch actively and passively. So of course, actively, we know it's going to be muscles, and passively, it's going to be some other things. So the fundamental movements of the foot and ankle occur within a plane that's perpendicular to the three classic axes of rotation: medial, lateral, anterior, posterior, and vertical. So a lot of the joints in the foot produce an oblique movement that's best described with the applied terms of pronation and supination. So this is different from pronation and supination at the forearm, which is a rotary movement. This is pronation and supination at the foot. In the foot are a combination of motions. Okay, and we'll talk about them. So flexion and extension in the ankle are called dorsiflexion and plantar flexion. So the ankle is the only place where those particular terms are used. Dorsiflexion and plantar flexion occur in the sagittal plane about a medial lateral axis of rotation, just like flexion and extension in other joints. The dorsiflexion describes bringing the dorsal part of the foot, the top of the foot, toward the anterior aspect of the tibia. And plantar flexion describes moving the dorsal part away from the anterior aspect of the tibia. So in layman's terms, you can think of dorsiflexion as, a lot of times we'll call it flexing your foot, and plantar flexion as pointing your foot, but we call them dorsiflexion and plantar flexion. Inversion and eversion occur in the frontal plane about an anterior posterior axis of rotation. So in this picture, I'm going to draw on that a little bit. This little symbol indicates the anterior posterior axis. So if you can imagine that as like a skewer sticking right through the ankle, the inversion and eversion are going to rotate around that axis. Okay, so that anterior posterior axis and the inversion and eversion are rotating around that anterior posterior axis. So it's a frontal plane movement around an anterior posterior axis of rotation. Inversion turns a point anywhere on the plantar aspect of the foot towards the midline. So that's like looking at the bottom of your foot to see if you have gum on it. Hopefully you'd be able to feel the gum, but who knows? So turning a point anywhere on the plantar aspect of the foot towards the midline. Eversion turns that same point or any point on the plantar aspect of the foot laterally or away from the midline. So inversion and eversion. I'll clear up my drawing. Okay, ab and abduction occur in the horizontal plane around a vertical axis of rotation. So the difference between this and ab and adduction of the hips and shoulders is that the ankle is at a plane that's 90 degrees from the plane of the shoulders and the hips. So ab and adduction, it's like doing windshield wipers with your feet. it occurs in a horizontal plane about a vertical axis of rotation. So adduction is the rotation of the foot toward the midline, and abduction is the rotation of the foot away from the midline. Do we have a joint that does all those motions? No, we do not. It's a combination of a lot of different joints contributing to the motion. So the ankle itself does not do ab and adduction. It's a combination of the joints in the foot that perform this motion. Pronation and supination are descriptions of combined motions that involve a lot of the joints in the foot. Pronation and ankle. Pronation is the combined movement of eversion, abduction, and dorsiflexion in any region of the foot and ankle. So the navicular is going to move towards the plantar aspect of the foot. That's our eversion, dorsiflexion of the ankle, and abduction of the foot. So it's a triplanar movement. Remember triplanar movement. Supination is a combined movement of inversion, adduction, and plantar flexion of any region of the foot and ankle. So they're not simple motions. We're going to talk about them a little bit more, but really what I want you to get out of this is I want you to get what are the combined motions that make up pronation and supination. Okay, and try it on your own foot. It's a good way to get it in your mind. So the ankle joint, or the talocrural joint, is created by the articulation between the trochlea of the talus, the dome of the talus, and the concavity formed by that distal tibia and fibula. It's often referred to as a mortise and tenon joint that is used by carpenters to make a strong joint. And you can see in this picture where that comparison comes from. So it's like the tibia and fibula are little pincers around the dome of the talus. You want to think of it that way. So there's 1 degree of freedom that permits ankle dorsiflexion and plantar flexion in the sagittal plane. Those motions are important to the functional movements of walking and squatting. We have to be able to dorsiflex and plantar flex our ankles. The muscles that course anterior to the medial lateral axis of rotation perform dorsiflexion, and the muscles that course posterior perform plantar flexion. Okay, just like flexion and extension in other parts of the body. So the interosseous membrane between the tibia and fibula binds the tibia to the fibula. It provides stability to the distal tibiofibular and talocrural joints. So it provides the tightness of that mortise and tenon joint. The anterior and posterior tibiofibular ligaments bind the distal tibiofibular joint, improving the stability of the mortise. So the ligaments are holding that joint stable. So the main ligaments that I want you to know are the deltoid ligament. It's on the medial side of the foot and it limits eversion. So picture that. The eversion is turning the plantar surface of the foot laterally. And you can see how the deltoid ligament would limit that if it's on the medial side. The lateral ligament, strangely enough, is on the lateral side. The name sort of gives it to you. That's nice. And it limits inversion. So that's turning the plantar surface of the foot medially. And so the lateral ligament limits that. So if people have an inversion sprain, a lot of times they sprain the lateral ligament. If they have an eversion sprain, they'll sprain the deltoid ligament. I've even seen people who had an inversion sprain on one foot and an eversion sprain on the other foot from falling on a hill. So it's crazy. You can get all sorts of great combinations. The ankle is most stable during maximal dorsiflexion when most of the collateral ligaments are tight and the plantar flexor muscles are stretched. And also the talus sort of wedges in between the tibia and the fibula when you're in full dorsiflexion, and that provides stability as well. The least stable position of the talocrural joint is full plantar flexion because most of the collateral ligaments and the plantar flexor muscles are on slack. So imagine high heels. That's the least stable position of the talocrural joint. And ballerinas who dance on point, that's a very unstable position of the talocrural joint. So they have to train for years to be able to do that and be stable. And they don't just stand there, they dance. So it's crazy. It's crazy what they can do with their feet. I'm going to leave that right there. So the subtalar joint is the articulation between the inferior surface of the talus and the superior surface of the calcaneus. It's designed to allow frontal and horizontal plane motions between the foot and the lower leg. So when we talk about ab and adduction, a lot of that is happening at the subtalar joint. It's essential for adapting to uneven ground surfaces or for cutting medially and laterally, like you're playing tennis or you're running side to side in football or soccer or something like that. So that subtalar motion is really important to the function of adapting to our foot and leg motions. The subtalar joint, the two motions that it allows are inversion adduction and eversion abduction of the foot. So it's that combination of movements. The horizontal plane movements are ab and adduction. The frontal plane movements are inversion and eversion. So during all subtalar motions, the trochlea is well stabilized in between that tibia and fibula in the talocrural joint. So that stability of that joint provides mobility of the subtalar joint. Pretty cool, right? So the motion at the subtalar joint allows independent movement between the calcaneus and the talus. And it's a path that goes through both the frontal and the horizontal planes. So while walking, this motion occurs when the calcaneus is free, and that's an open chain motion, or when it's fixed, held under the body's weight with your weight on your heel. And that's a closed chain motion. So when we're in the stance phase of walking, the leg and the talus move over the fixed calcaneus. So that we have, even on these smaller joints, we have open and closed chain movements. So the transverse tarsal joint is the talonavicular joint and the calcaneocuboid joint. So those two joints combined form the transverse tarsal joint. It allows the midfoot to move independently of the rear foot. So the transverse tarsal joint permits the most pure form of pronation and supination. Pronation has nearly equal elements of eversion, abduction, and dorsiflexion. And supination has nearly equal elements of inversion, adduction, and plantar flexion. Other joints in the foot do pronation and supination, but it's most balanced in the transverse tarsal joint. So the medial longitudinal arch of the foot is the load-bearing and shock-absorbing foot structure. There are active muscle forces that can help support the arch, but they're generally not required unless you have flat feet. Pes planus is the clinical word for flat feet. The arch normally lowers and the rear foot everts slightly to maintain forces at tolerable levels. So normally we have that medial longitudinal arch, and then we have a transverse arch going sideways to maintain the cushioning effect of our feet. So usually the medial longitudinal arch is supported by passive structures, and you don't need active muscle structures unless those passive structures have broken down. So the primary passive supporting structures of the medial longitudinal arch are the plantar fascia, which is letter D on this diagram, the spring ligament, which is letter A, a lot of the plantar ligaments, which are B and C, the integrity of the talonavicular joint. So a lot of times people with flat feet, the navicular moves distally and it hits the ground. the deltoid ligament, and the shape of the tarsal bones. So the shape of the bones is a passive structure on the arch. So these are all passive supporting structures, ligaments, bones, and the joints themselves. So active supporting structures include the tibialis posterior, the peroneus longus or fibularis longus, and the intrinsic muscles of the plantar aspect of the foot. So we're going to talk about the extrinsic muscles of the foot, but we are not going to get into detail on the intrinsic muscles of the foot. That is really a specialty area. It's not considered entry level. And so we will talk about them in this respect, like they're part of the active support for the arch, but we're not going to talk about them specifically and name their origins and insertions. So if you think of it, the passive supporting structures are bone and ligaments. The active supporting structures are muscle. That makes sense, right? The distal foot joints include tarsometatarsal joints, which are between the cuboid and cuneiform and the metatarsal bases, and the metatarsophalangeal joints, which are the metatarsal heads with the bases of the phalanges, and the interphalangeal joints. All three of those sets of joints play important roles in walking. So the mobility of our foot is hugely important for walking and for balance. So the tarsometatarsal joints are where the metatarsal bases articulate with the distal surfaces of the cuneiforms and the cuboid. All of those can be palpated. All those joints can be palpated. In general, they're relatively rigid, except for the first, which allows plantar flexion and dorsiflexion coupled with inversion and eversion. So different areas of the foot will have different mobility. So if you grab a hold of somebody's foot or your own foot and kind of just test the movements in there and see, there are areas that are really tight and rigid, and they're supposed to be, and some that have relatively more movement. So when we talk about the ray is the from the tarsals through the metatarsals through the phalanges of an individual digit. So when we look at this picture, let me draw on here. This is the first ray. So this whole series of bones here. This is the second ray. So it's that whole chain of bones that leads out to an individual toe. Hopefully that makes sense. So the metatarsophalangeal joints are formed between the convex head of the metatarsals and the shallow concavity on the proximal phalanges. They allow similar motions or analogous motions to the metacarpal phalangeal joints in our hands: extension, flexion, ab and adduction. Of course, in the foot, we call it dorsiflexion, plantar flexion, and ab and adduction. So the metatarsophalangeal joints in the foot move a lot like the metacarpal phalangeal joints in the hands. They're analogous. The interphalangeal joints, so each toe, besides the big toe, has a proximal and distal interphalangeal joint. The big toe only has one interphalangeal joint, just like the thumb and the fingers. Motion is limited primarily to flexion and extension. Extension is typically limited to a neutral position of the joint. So even though you can stretch your toes into hyperextension, you don't get a lot of motion in the interphalangeal joints. Most of the motion is coming from the metatarsophalangeal joints. Okay.